Good day, my name is Nikhil Oliveira, and alongside my colleagues Lorraine Joseph Kandathil and Professor Dr. Georgi Chernev, I'm going to be presenting to you a very unique case of one-step surgical removal for intermediary thickness cutaneous melanomas between 1 to 4 millimeters thickness. Before I start, I'd like to make declarations that all authors declare no conflicting interest and there was no research funding received for this study. So I present to you a clinical case of a 48-year-old female. She was a Fitzpatrick phototype 2. She had a primary complaint of a lesion on the lateral aspect of the thigh that appeared roughly 5 years prior. The patient observed a steady growth over the last 3 to 4 years. The lesion appeared to grow more rapidly in the vertical plane in the last year, and she decided to seek a dermatological consultation at our clinic. Some anamnestic data, past medical history: she had no concomitant diseases, she had no surgical interventions. Her family history of malignancy was normal. She had no pulmonary, cardiovascular, or metabolic diseases. She did not have any allergies or medications at the point of presentation. Her social history: she did not smoke and her alcohol intake was normal. She had a good balanced diet, she was married, and she did not have any recent travel outside Bulgaria. So, on dermatological examination, we saw a single nodular dark tan-brown lesion on the right thigh on the lateral aspect. It was roughly 1.5 centimeters in diameter. On palpation, it was smooth but firm, and there were no signs of any crusting or erosions or any signs of ulceration. And here once again we see a solitary nodular hyperpigmented melanocytic lesion, which, as mentioned, measuring 1.5 centimeters in diameter, which was on the lateral femoral region of the right thigh. It was dome-shaped with evenly pigmented dark brown tan discoloration. On palpation, it was firm, smooth with elevated surface. The boundaries of the lesion were tapered but mostly well demarcated with surrounding tissue and was symmetrical, and no ulceration or bleeding was present. So clinically and dermatoscopically, the pigmented nodule met the clinical requirements for a nodular malignant melanocytic lesion. It was elevated, firm on the touch, and it was growing. On dermatoscopy, we saw impaired melanocytic network, areas of regression, and heterogeneous color was present. As well as that, clinical and dermatoscopic data was in favor of a melanoma no more than 2 millimeters and in intermediate thickness. So we did laboratory workup with hematological status, and the eosinophils was lower than normal at 0.8%. Biochemistry, including HDL, LDL, and LDH, were also below the normal values. S100, however, was less than 0.11 and was within limits. Imaging studies was done with chest, CT, and abdomen that showed no signs of dissemination or any signs of metastatic spread. There was an incidental finding of cholelithiasis. Preoperative echography was done for lymph nodes, for the femoral, inguinal, pelvic, and mesenteric lymph nodes, which were without any evidence of metastasis. And overall, based on the clinical, dermatoscopic, and paraclinical data, a working diagnosis of intermediate thickness nodular melanoma between 1 to 4 millimeters was made. So we performed a treatment strategy, a surgical treatment strategy, according to the AJCC two-step surgical procedure guidelines, and the primary surgical excision was performed with a field of operative surgical safety of 0.3 to 0.5 centimeters, which is recommended by the AJCC guidelines. And here on your right, you can see a preoperative image of the surgical safety margins that were drawn. Here once again we see intraoperative images of the incision of the lesion with the surgical safety margins and the depth as well. And the excised tumor was sent for histopathological analysis, which was confirmed as nodular malignant melanoma of the femoris dextri. The stage came back as 1B, Clark level 4, Breslow thickness of 2 millimeters, TNM classification PT2B, N0, N0. Class A, there was no ulceration on histology, there was high mitotic activity, and there was well-defined lymphocytic stromal reaction. As well as that, there were clean resection margins. Now, according to the American guidelines, the recommended treatment varies from 1 to 2 centimeters surgical safety margin in combination with sentinel lymph node drainage. This is all done in 2 surgical sessions for intermediate thickness melanoma. However, these recommendations follow the variable resection zone of the secondary excision, according to the American Joint Committee of Cancer. Now, this variability, since the secondary excision may be between 1 to 2 centimeters, according to the AJCC, which are very arbitrary and random. Following these AJCC guidelines, the patient was sent to the National Oncological Hospital for evaluation and secondary re-excision and sentinel lymph node biopsy a week later. And a secondary re-excision was performed in 1 centimeter in all directions from the previous scar, which was carried alongside a sentinel lymph node biopsy drainage of the inguinal lymph nodes. And on your right, subsequently, we can see good wound healing post-operative to the secondary excision. As well as that, there was a successful lymph node biopsy drainage, which was performed at the National Oncological Hospital, which came back negative for metastatic dissemination. And here on your left, you can see these images of the inguinal lymph node biopsy and drainage. However, as according to the AJCC guidelines and the procedures that are mentioned, there was no reciprocity between clinically determined preoperative surgical margins and histopathological confirmed postoperative surgical margins. So, key points that need to be raised in this presenting case include features of the intermediary thickness melanomas and how they are classified according to the Joint Committees of Cancer, including the American and European counterparts. The surgical approach in the treatment of cutaneous, borderline intermediate thickness class A melanomas, and the gaps in the American Joint Committee of Cancer recommendations that could lead to potential pitfalls. And we will introduce a new and modernized guidelines in the form of OSMS, which is the one-step melanoma surgery, and the advantages it possesses in comparison to the American and European Joint Committee of Cancer recommendations for treating melanomas. So, malignant melanoma is a cancer with a growing frequency worldwide and currently is the 5th most common oncologic disease in men and 6th in women. Complete surgical excision is the gold standard treatment strategy, with identification of the tumor depth as the most important prognostic factor for patients with cutaneous melanoma. Currently, all surgical treatment strategies follow the recommendations of the AJCC, i.e. the American Joint Commission of Cancer, and the European equivalent, the European Joint Committee of Cancer. They broadly classify all melanomas in 4 categories: melanoma in situ, thin, intermediate, and thick melanomas, based on a predefined category of breast lobe thickness. And here we have a table that has been done by the American guidelines, and we can see here whereby in situ is performed with a surgical margin of 0.5 to 1, always in 2 surgical sessions. The intermediate thickness melanomas are from 1 to 2 and 2 to 4 and are performed between 1 to 2 centimeters for a thickness of 1 to 2 millimeters, which is always done in 2 surgical sessions. And for tumors with a thickness of more than 2 millimeters, you always perform 2 centimeters as surgical safety margins, which is always done in 2 surgical sessions. Now, the important thing to remember is that these are recommended surgical sessions which are clinically measured from the edge of the lesion or prior to biopsy at the time of surgery. These are not histological margins as measured by the pathologist. And these margins can be modified as well for functional considerations or anatomical locations. Margins also larger than 0.5 centimeters may be necessary for melanoma in situ, in particular the lentigo malignanti. Now, these current guidelines set by the AJCC and European counterparts classify intermediate thickness melanomas as 1 millimeter to 4 millimeters in depth, and the treatment to be conducted in 2-step surgical session. Based on the current guidelines, the primary excision is conducted with no more than 0.3 centimeters in all directions, followed by a histological verification of tumor thickness. Thereafter, a secondary re-excision in patients with cutaneous melanomas with a tumor thickness between 1 to 2 millimeters is performed, with a variable 1 to 2 centimeter complete surgical margin in the frame of 2 surgical sessions. And this is also done with a parallel lymph node drainage of a sentinel lymph node biopsy. This is all in accordance with AJCC guidelines. Here we have the current and the most modified form of the AJCC recommendations, and once again this table shows the splitting of the 2 surgical step procedure. So if we look at the highlighted yellow groups, which are your intermediate thickness, which can be categorized as class A for 1.01 to 2 millimeters, which has a primary excision of 0.1 to 0.3 centimeters, followed by a secondary excision of a variable margin between 1 to 2 centimeters in parallel to sentinel lymph node drainage. Class B can be categorized between 2 to 4 millimeters breast lobe thickness, which once again has a primary excision of 0.1 to 0.3 centimeters, followed by a secondary 2 centimeter margin in all directions with SLNB. And these are the total margins that need to be performed. These recommendations again are clinically measured, and they are not histologic margins as measured by the pathologist. What's interesting to note, however, is that there is no reciprocity between clinical and histopathological measured margins, and this is not mentioned by the AJCC or EJC guidelines, and it's not required by these guidelines as stated. And there is always a necessity of 2 surgical sessions. Now, Sweater recommends the absolute same surgical margins for class A, which is between 1.01 to 2 millimeters thickness, and class B, which is 2 to 4 millimeters thickness, treating them exactly the same without any clinical or histopathological reciprocity. Is this okay for the patients? So, what are the American guidelines actually suggesting? That we treat all intermediate thickness melanomas within 1 to 4 millimeters with a variable margin of 1 to 2 centimeters, but always with a sentinel lymph node biopsy in 2 surgical sessions. What differentiates the 2 intermediate classes of AJCC, class A and class B, apart from the fact that there is variable margins of 1 to 2 centimeters? These recommendations do not specify precise fields of surgical certainty, which creates difficulties for both the clinician and the patient, and it leaves room for much confusion. Some issues that are related to the variability of these margins. So based on the AJCC guidelines, what are these variabilities suggesting? The variability allows for confusion, where a cutaneous melanoma with an estimated tumor thickness of 1.01 millimeters, considered as intermediate class A, but also class B between 2 to 4 millimeters, may be treated equally or with the same surgical margins as a thick melanoma, which is greater than 4 millimeters thickness. And they both allow, or they both can potentially allow, for 2 centimeters overall surgical safety margins with an SLNB. Even in this way, we are treating intermediate thickness melanomas class A and B always with 2 centimeters surgical safety margin and sentinel. But for thick melanomas, for example, which are more than 4 millimeters thickness, we are treating them with 2 centimeters surgical margins, but more often than not without sentinel lymph node biopsy. Variability allows for melanomas of the same tumor thickness to be treated surgically with different resection margins, which may lead to different prognoses in patients in the long run. Again, the variability causes the treatment for different types of tumors with the same or different tumor margins, surgical safety margins, which can lead to different prognoses in the long run. The broad category of 1 to 4 millimeters intermediate thickness present a wide array of prognostic characteristics and the tumor heterogeneity, of course, and are not subjected to a clear treatment strategy. We are not looking at these patients as individuals, but we're treating them under the guidelines which do not consider for tumor heterogeneity and specificity for certain patients. The European consensus advocates for more precise recommendations, however, for intermediate thickness melanomas with the same two-step approach as the AJCC. Now, in comparison to the European versus the American colleagues, the European guidelines give better accuracy in terms of treatment for medium thickness melanomas, i.e. those between 1.01 and 2 millimeters thickness. However, according to the AJCC recommendations, they still consider them under 2 surgical sessions accompanied by a draining lymph node. Table 3 here presents the modified version of the European Joint Committee of Cancer recommendations, and tumors with a Breslow thickness of less than 2 millimeters are always treated with a surgical safety margin of 1 centimeter overall in under 2 surgical sessions. And those with greater than 2 millimeters are again treated with 2 centimeters surgical safety margins in all directions, again performed in 2 surgical sessions. A sentinel lymph node biopsy is performed in patients with tumor thickness greater than 1 millimeters or greater than or equal to 0.8 millimeters with additional histological risk factors. For example, ulceration, or if there's mitoses between a millimeter squared, or if they see any microsatellites. Reciprocity, once again, between clinical and histopathologically measured surgical margins are not required nor mentioned in these guidelines, and once again, they are always suggested to do it under 2 surgical sessions. So what do both these guidelines overall summarize? That both AJCC and EJC want to perform these surgical treatments in 2 surgical sessions and do not want clinical or histopathological reciprocity, as it's not mentioned in their guidelines. So what are the weaknesses that we can look at? Well, the main disadvantage lies in the fact that the recommendation for both the European and American committees of cancer are to be performed with 2 surgical sessions. The EJC guidelines also do not mention the need for reciprocity between clinically marked and histologically measured surgical margins. In practice, however, it turns out that melanomas of the same tumor thickness may be treated surgically using different resection margins and would be showing different prognostic results for these patients overall. The recent update in 2021 by the American Joint Committee of Cancer Guidelines suggested the possibility of extending the surgical excision even after the surgical session, if the clinician is of the opinion that the resection lines are clear of tumor tissue, but they pass relatively close to it according to histopathology. What does this tell us? Well, this postulates that the AJCC guidelines and their update is not supported by any additional data parameters regarding the concept of proximity, leaving the possibility of a third excision open, but at the same time, its implementation remains neither recommended nor mandatory. This points to the lack of reciprocity between clinically marked and histologically measured surgical margins. And here we can see the exact statement made by the American guidelines, which says, for histologically negative margins on the wide excision specimen, the ICCR and CAP guidelines do not require reporting the microscopically measured distances between tumor and labeled lateral or deep margins, and this measurement should not generally impact clinical decision making. However, narrow pathologic margins, particularly of the invasive component, are associated with higher risk of local recurrence, and this information may warrant consideration of a further surgical resection. The guidelines could easily recommend an increase in surgical safety margins in one surgical session to reduce the number of surgical sessions. However, this suggests the opposite. And once again, after the update, there is no talk of reciprocity. The potential implications for such ambiguous recommendations again falls on the clinician, who will more often than not end up being forced to perform 2, if not 3, if not 4 surgical sessions to ensure that overall clean resection margins are met by these guidelines. And these guidelines fail to give clear or precise surgical margins. What are the implications of this? This could lead to issues such as further surgical complications, additional trauma to the patient, and aesthetic issues, to name a few. These guidelines completely fail and disregard the patient's well-being and treatment. So, considering all these irregularities and lack of precision by the AJC and EJC guidelines, we propose a new set of recommendations in the form of a personalized one-step melanoma surgery, OSMS. The OSMS personalized approach aims to follow a more precise and tailored treatment plan that reaches the intended final result of both recommended guidelines, but in one surgical session. The OSMS identifies the 2 borderline intermediate thickness melanomas class A and B and suggests a more adequate recommendation for their management in one surgical session. For example, a 2 cm with SLNB for class A in one session and a 2 cm for class B in one session. Here we present the modified and updated personalized one-step melanoma surgery recommendation guidelines according to our colleagues. And here for intermediate class A and class B, we clearly mandate a 2 cm with SLNB for both classes, regardless of the tumor thickness. In this way, there is mandatory clinical and dermatoscopic evaluation, echographical tumor thickness measurement preoperatively, and when possible, confocal microscopy additionally should be performed. With the requirement for absolute reciprocity between preoperatively measured and histopathologically established postoperative surgical margins, there is always and only the necessity for one surgical session. What are the advantages of the personalized OSMS guidelines? Well, firstly, it supports and defines the approach for clinical features, dermatoscopic findings, which should be indicative of melanoma, and preoperative ultrasound determination of tumor thickness. And if clinically and dermatoscopically indicated, we can also use confocal microscopy for medium thickness and thick melanomas, where there is areas of regression and non-pigmented melanomas. In practice, this personalized surgical approach for the treatment of melanomas achieves the same intended end results as our American and European colleagues, and which are achieved in 2 surgical sessions, but we perform it in 1 surgical session. In addition to being single stage, the OSMS guidelines from 2021 now require reciprocity between respect clinical and histopathologically established surgical margins. Another advantage is the unification of the treatment of moderately thick Class A and Class B melanomas with that of thick melanomas, with a total resection margin of 2 centimeters in all directions, in line with the AJCC recommendations. And in over 98% of cases, this complies with the recommendations of AJCC and the EJC. This is a serious premise for the application of this method, is the presence of an excellent clinical and dermatoscopic evaluation, as well as thorough knowledge in the field of skin ultrasound, which is paramount. What are the overall benefits and who benefits the most? Well, the overall benefit is fewer interventions. And who benefits? The patient. The greatest advantage to OSMS is eliminating the need for a second procedure. This gives easier patient traceability and compliance. It also increases and has a higher cooperation by the patient. Most often than not, a second surgery will always and often put doubt on the success of the treatment, even if the first surgical session was successful with clean resection lines. There is reduced hospital stay for the patient. There is 2-fold reduction in surgical complications, which benefits the patient. There is reduced psychological trauma and discomfort for the patient. And most importantly, there is reduced cost in regard to the patient as well as for the institutions. Overall, OSMS offers precise guidelines with overall benefits centralized around the well-being of the patient. In conclusion, we present a case of a nodular melanoma with a 2 mm Breslow thickness treated in 2 surgical sessions. We thematize the possibility for using preoperative echographical tumor measurement where the data would be in favor of melanoma with tumor thickness below 4 mm and more than 1 mm. In that case, we suggest the performance of 1-step surgical procedure with 2 cm surgical margin and sentinel lymph node biopsy simultaneously. Where we have clear clinical and dermatoscopic data of the primary lesion in favor of melanoma, we can perform preoperative echographical tumor thickness measurement following the OSMS surgical guidelines. Additionally to reducing the surgical session from 2 to 1, we suggest for the first time in world literature the implementation or reciprocity between clinically measured and subsequently histopathological established surgical margins. This patient was an ideal candidate for a personalized OSMS surgical treatment, and when using high-resolution ultrasound to determine preoperative thickness to employ a single surgical session. In this case, 2 cm complete surgical margin with sentinel in 1 surgical session. 1-stage melanoma surgery relies on clearer therapeutic algorithms and provides better therapeutic control within a single surgical session in melanoma patients with completely indicative clinical and dermatoscopic criteria in favor of cutaneous melanoma and preoperatively performed tumor thickness measurement via skin echography. And with that, I'd like to thank you for your attention, and please look up bolsds.com for the Bulgarian Society of Dermatological Surgery to look at the work we're doing here. Thank you.